Hello, dear patients and our followers. I'm Dr. Ahmedov, hair transplant surgeon from Smile Hair Clinic, Istanbul, Turkey. Today, we are going to discuss with you the case of the patient who underwent a hair transplantation surgery in our clinic almost 1 year ago in October of 2025. This is a 33-year-old male who had the mixed type of the hair loss. The front area is a Norwood type 3 of the hair loss, and the crown area is a Norwood type 4V of the hair loss. When we evaluate the patients for the hair transplantation surgery, the first thing we do, we see what's the level or degree of the hair loss they have. For this purpose, we use the Norwood-Hamilton scale. And on Norwood-Hamilton scale, the hair loss in man is staged, simply speaking, starting from level 2 up to the level 7. 2 is the lowest, and of course 7 is the highest degree of the hair loss. The higher is the degree of the hair loss the patient have, the higher is the need for the grafts we need to get, number one, and number two, high is the probability that some patients may require more than one surgery. But in some patients, there cannot be a specific degree of the hair loss. In some areas, for example, the front and the mid-scalp may be in the early stage of the hair loss, but the crown area may be very progressive type, or the front side may be progressive, for example, Norwood type 4 to 5 in the front side, but Norwood type 3V, the small notch in the crown area as well. So it's very important for us to find the degree of the hair loss, because as we mentioned earlier, the higher is the degree of the hair loss, the higher is the need for the grafts we need to get from them. So the patient's planning was done as we talked earlier. He has a mixed type of the hair loss, Norwood type 3 in the front area and Norwood type 4V in the crown area. For this type of patients, for Norwood type 3, on average, we may need something around like 2,400, 2,500, up to 3,000 grafts in the front area. Of course, depending on the size of the open area, the density you want to acquire, expectations of the patient. And for the Norwood type 4V in the crown area, it needs at least something around 30 to 40 centimeters squares in the crown area. We may need at least something between like 25 up to 30 grafts per centimeter square to create a density difference. So something around like 700 to like 900 grafts would be needed for the crown area itself. The patient's planning was done, the reconstruction of the front hairline. The front hairline is the key point when doing the planning of the surgery. We, as a general rule for the hair restoration surgery, it's a very pretty much frequently missed in some of the clinics. The hairline, as a general rule, should be high, conservative. Why? For a couple of reasons. First of all, the hairline should match the age of the patient, because as women get older, our hairline naturally recedes more to the back, giving us more mature look. So we don't want the gentleman to be in his 40s, 50s, 60s in the future with the hairline of the boy in his 20s. That's number one. Number two, keeping the hairline high and conservative gives us the chance to give the patient more coverage and the density with the lower number of the grafts, thus keeping the donor reserve for future surgeries just in case if there will be a need. Okay, and of course, when you do an aggressive lowering of the hairline, even though it may look fancy in the beginning, but years later when the patient gets older, and if by any chance the pre-existing non-transplant hair continue to recede more to the back, there will be a phenomenon called like an island of the hair in the front side and some empty spots around it. So these are all important factors. So when designing the hairline, it's not only about today, but it's about upcoming 10, 15, 20 years ahead. So we have to be very, very careful about this one. Of course, the patient's consideration are taken into attention, but these rules also should be always kept at the back of our mind. So the hairline, as we told you, looks natural and actual for a very, very long time. So the planning was done, the front hairline was designed, and we were able to extract from him 4,000 grafts. From this number, from 4,000 grafts, 2,900 grafts were implanted in the front area and front forelock. We call the front frame of the face. Around 300 grafts were used to add some more density in the mid-scalp, and 800 grafts were implanted in the crown area. Here we can see the result of the patient exactly 1 year after the surgery. You can see our main purpose of the surgery, the reconstruction or reframing of the face is done. Here's a good density in the front line. It looks very natural. It doesn't look like a part of the thing that was stuck in there but never belonged this place. It looks natural, mature hairline. The front area is in a good density. We were able to improve overall density in the crown area. Yes, it's not in a perfectly well condition with super high density, but it's a great improvement in this area. So the main purpose of the surgery, the reconstructed front hairline and adjustment of the density in the crown area were required. When we were doing the pre-planning with the surgery, we in details also discussed the point that he may need the surgery in the future over the years if by any chance he continues to lose some hair, number one, or if you will want to add more dense, especially in the crown area. One of the most frequent questions we get from our patients during our consultations is that whether we advise the patients to go with the medical treatment. It can be finasteride, minoxidil, or other options. I always tell to the patient, especially with the patient with the androgenetic alopecia, we strongly advise the medical treatment. It can be finasteride, it can be minoxidil, but ideal will be the combination of both of them. I always tell it's like playing with the puzzle. You have the hair loss, we fit it in. But if over the time your non-transplant hair, I mean pre-existing hair, continue to fall out, you will end up with new empty spots between them. So the surgery is basically needed to cover the open areas when unfortunately the hair is gone forever, but the medical treatment is the key to prevent furthermore loss and protect your pre-existing hair. So they basically should complete each other, because as I always tell my patients, the best surgery is not having the surgery if it can be delayed with the medical treatment. So here you can see an example of how the life-changing surgery may improve the quality of life of the patient. The patient is happy, we are happy, he's in a good condition, he's very happy. We keep in touch with him still more than 1 year after the surgery. And the last but not least important thing is most of the time we get the questions when to have the surgery for the patients. The key point here, there is very big misconception. Sometimes patients think like this: let me lose as much as I can and then come for the surgery so I can do everything in a single surgery. It's a wrong approach. Just like in any other medical field, we tell the patients at the early stage the medical treatment is the key, but starting from Norwood type 2 or 3 basically. If the hair loss has started, we advise them to have the surgery earlier, because they will require much lower number of the grafts, and stick up with the medical treatment after that. So it's the best option, because the more progressive hair loss becomes, the higher number need for the grafts we have to get. That's number one. Number two, and we will not be sure whether the donor area will have the reserve to cover everything. So early diagnosis, early treatment, early intervention if needed, and we are happy, the patient happy. Stay tuned. If you have any questions, you will be able to ask them just below the video in the comments, and we'll be glad to answer them. Thanks for watching, and as we mentioned earlier, stay tuned.